Welcome to Eye Experts University. I'm Dr. Eli Sluch, and today we'll be talking about the cranial nerves. The cranial nerves are a complex topic, and we'll be focusing mostly on the way the cranial nerves affect vision and eye movements. So we'll be focusing on the optic nerve and the visual pathway towards the occipital cortex, the way cranial nerves move eye muscles, the way cranial nerves innervate sensation in the face, and some other auxiliary functions. The only useful function of the nose is really to hold eyeglasses up, but we will still talk about it. So the olfactory nerve is the nerve that innervates our sense of smell. It has unmyelinated nerve fibers that pass through the cribriform plate and into the nasal cavity. The only real correlation to eyes in this scenario is Foster-Kennedy syndrome, in which a compressive lesion can cause atrophy of both cranial nerve 1 and 2, which will cause an ipsilateral decrease in vision as long as loss of smell on the same side. The optic nerve is an ophthalmologist's favorite nerve because it is responsible for our vision. It is a big nerve. It has over 1.4 million axons. And it has several portions. It has the intraocular portion, which is unmyelinated. It has the intraorbital portion where it passes between the eye and the orbital canal. It starts being myelinated there and it's already surrounded by a dural sheath. Then it passes through the canal, which is where it passes through the bony portion. This is where it can get in trouble with trauma and you can get traumatic optic neuropathy in case it hits too hard against the bone. And then there's the intracranial portion until it crosses at the chiasm. The intraocular part of the optic nerve is unmyelinated, and it starts with the superficial nerve fiber layer, and it forms the optic nerve head. This is what we can see during ophthalmoscopy. The macular fibers form about one-third nerve, and they are placed laterally. As they flow through the nerve, they will then pass through the cribriform plate. This is where we think the stress of glaucoma starts affecting the nerve and slowly induces optic nerve atrophy. The cribriform plate is pretty dense collagen. Now, if we look at the circulation of the optic nerve, we see that the intraocular portion is mostly supplied by the ophthalmic artery, and when you are at the level of the cribriform plate, you start seeing collateral circulation from the short posterior ciliary arteries as well. Once we go past the cribriform plate, the nerve becomes myelinated. The intraoral portion is about 25 to 30 millimeters long and it has some slack. The slack is necessary so the eye can move without putting the optic nerve on stretch. As you can imagine, if you stretch a nerve, nothing good happens. This is the problem in severe proptosis. You can actually get optic nerve damage when the nerve is placed too much on stretch. So the nerve travels within the muscle cone and it's in a finite space. It's in the orbit, which is again is about 30 milliliters. If you get a retrobulbar hemorrhage, this is where the blood is gonna bleed. And as you can imagine, as you're adding more volume to a confined space, you're gonna increase the pressure. So this pressure can actually shut off the circulation to the nerve. And because the circulation shuts down, you get damage and you can lose vision. As mentioned earlier, the interorbital portion of the optic nerve is surrounded by a meningeal sheath, which is made out of the pia, which has the vascular supply, the arachnoid, and the subarachnoid space, which hosts the CSF, and the thick dural sheath that then wraps the whole thing in a nice bundle. When there is a rise in intracranial pressure, this increases the pressure on the whole CSF system. And this will also affect the venous pressure in the nerve, thus keeping the veins from collapsing. So the spontaneous venous pulsations that you would normally see during ophthalmoscopy, you may not see during your exam in cases of increased intracranial pressure. However, that's still a pretty subjective test and not 100% reliable. The optic nerve intracanalicular portion is pretty vulnerable for several reasons. When it passes through the canal, it only has sole blood supply from the ophthalmic artery. It is tethered to the canal, and there is no extra space. Because the bone is a good force conductor, because it's dense, it will transfer all the force to the nerve. And because there is no extra space, if there is any swelling in the nerve from damage or some other process, it will get choked out and cause compartment syndrome. Once the nerve exits the canal, it has much more blood supply from the anterior communicating and the anterior cerebral arteries, which lie over the optic nerve. Therefore, when you get an aneurysm in one of those, it can cause optic nerve compression. Once the nerve exits the canal, its blood supply now comes from the ophthalmic artery and branches of internal carotid. And now it has more space because it's no longer inside a tiny bony space. The anterior cerebral and anterior communicating artery run above and near the optic nerve, so an aneurysm in one of those locations could cause optic nerve compression. The main message here is that the optic nerve is mostly supplied by the ophthalmic artery, which starts traveling with it through the optic canal and all the way through the intraorbital portion. Going anterior to posterior, the nerve fiber layer is supplied by the central retinal artery. Hence, when you have a stroke to the central retinal artery, you stroke out the retina, specifically the nerve fiber layer portion and some of the more inner retina. The prelaminar portion is supplied by the short posterior ciliary arteries and some choroidal circulation. The laminar portion is still supplied by the posterior ciliary arteries, but instead of being supplied directly from the choroid, it's being supplied by the possible collaterals from the choroid through the Zinn-Haller circle. The retrolaminar portion is already supplied by the PL blood vessels and posterior ciliary arteries and some of the central retinal artery branches. A watershed area exists in between the areas of distribution of posterior ciliary arteries. That's how you can get a sectoral and a ION. Unlike the retinal arterioles, the central retinal artery has a layer of smooth muscle and fenestrated internal elastic lamina. The ciliary retinal artery is collateral circulation present in about 30% of the population that can supply the central retina in the event when the central retinal artery has stroked out. It is important to remember that anatomically the arterioles run over the veins. Thus, when you have a higher blood pressure, you can see the arterioles tense up and will actually cause venous compression on ophthalmoscopy. The optic nerve reaches the optic chiasm in order to decussate, which means the fibers are going to cross over to the other side. Now, why is that? If we look at the diagram, we will see that the temporal visual field of one eye corresponds to the medial visual field in the other eye. Therefore, the fibers need to cross over in order for the visual fields to align in the brain. The nasal retinal fibers will then cross over to the contralateral tract. It turns out that actually 53% of the fibers cross over and only 47 stay behind. So hypothetically speaking, you could get a relative afferent pupillary defect if you cut the optic tract, because there's a 6% difference, but the percentage is small, it's probably negligible. Now, the Wilbrandt knee is a portion of the fibers in the inferior nasal fiber loop that go a little bit anterior before going over. This can cause a junctional scotoma if they get hit by a lesion strategically, but that's pretty rare. The optic tract is the part of the optic nerve that travels through the postchiasmal section into the lateral geniculate nucleus. Not all of the optic nerve fibers go to the lateral geniculate nucleus, only about 70%. The other 30 then go to the pretectal and the superior colliculus nucleus, so they can focus on the pupil reflex as well as the saccadic eye movements. The lateral geniculate body is organized into layers. Layers 1, 4, and 6 take care of the contralateral optic nerve fibers, and 2, 3, and 5 take care of the ipsilateral, because as you remember, they crossed over at the chiasm. Specifically, layers 1 and 2 are responsible for motion, while 3 through 6 focus on color and high contrast. The optic radiation represents a large structure that connects the lateral geniculate nucleus on each side to the occipital cortex. This structure is so large, it runs through two different parts of the brain. So the inferior fibers run through the temporal cortex, and they're called the loop of Meyer. Meyer for medial cortex. Those represent the superior visual field, and a defect there will cause a pie in the sky visual field defect. Versus the superior fibers run through the parietal lobe, and those represent the inferior visual field, aka pie on the floor. The visual cortex of the occipital lobe is the thinnest area of the human cerebral cortex, only 6 cellular layers. It specifically occupies the superior and inferior lips of the calcarean fissure. The central vision from the macula is actually the most posterior portion of the occipital lobe and has the largest representation. The peripheral vision is more of the anterior portion of the calcarean fissure. The occipital lobe has a dual blood supply of the posterior and middle cerebral arteries, but the middle cerebral artery usually supplies the central vision. So frequently when you have an occipital lobe stroke, it strokes out your peripheral vision, but your central vision may be spared, all thanks to the middle cerebral artery. Now let's talk about lesion localization. So, if you look at the diagram, you will see where you can get a lesion and what kind of visual defect you're going to get. So, number one, when we cut the optic nerve, that eye doesn't see anymore. That optic nerve is cut, so we get a complete block in visual field on that side. If we cut at the chiasm, because we're only cutting the fibers that cross over, and it's only the temporal visual fields that cross over, we get a temporal visual field defect on both sides, aka a bilateral temporal hemianopia. If we go past the chiasm, now we start just knocking out the contralateral visual field, so we have a hemifield defect. When we get to our optic radiations, since they run on different lobes of the brain, we can either get a pie in the sky, which is our medial lobe, or we can get a pie on the floor, which is a parietal lobe. If we damage the optic radiations at the end, where we have the occipital cortex, we typically knock out the peripheral vision, but frequently the central vision is spared thanks to the middle cerebral artery. Cranial nerve 3 starts off in the midbrain with its nucleus and is a much smaller nerve compared to optic nerve, only 24,000 fibers. It supplies almost all the extraocular muscles except for the superior oblique and the lateral rectus. The cool thing here is while most things have a side, the central caudal nucleus actually supplies both levator palpebrae superiors simultaneously. Thus, your eyes open at the same time. The superior subnucleus crosses over and actually innervates the contralateral superior rectus. All the other muscles are ipsilateral. The Edinger-Westphal nucleus, which is probably the most famous in the group, is the one that the parasympathetic innervation through the ciliary muscle and the pupillary sphincter. The nerve travels below the posterior cerebral artery and above the superior cerebral artery. But what's most important here is that it travels lateral to the posterior communicating artery. That is the site where the aneurysm would most commonly happen, and you can get a cranial nerve palsy that is compressive. Now, as we remember, the pupillary fibers are the ones that run on the outside of the nerve. Therefore, if you have a compressive optic neuropathy, the pupil will be affected before the motor function. As I remember from the anatomy lectures, the cranial nerve 3 does run through the cavernous sinus, and then it splits into the superior and inferior divisions after it goes through the superior orbital fissure. Let's talk about the pupillary light reflex. So the light hits the retina. They will then travel ipsilaterally if we are testing one eye, but there's also contralateral fibers that again will decussate at the chiasm. All the nerves will then go to the Edinger-Westphal nucleus, which then has a bilateral innervation, and then it's going to send the efferent branch through the cranial nerve 3 into the ciliary ganglion and cause the pupil to constrict. The afferent pupillary defect refers to the fact that if there's damage in the afferent fibers, which are red on the diagram, the response to the light will be weaker than in the other eye. Therefore, you will be able to tell that based on the pupillary response. Now, it's important to know that it's relative. Therefore, if you have equal lesions on both sides, you will not be able to tell if there is a relative afferent pupillary defect. As you remember, this does not rely on the other 70% of the fibers that go to the lateral geniculate nucleus. This is a midbrain thing. So even if the rest of the stuff doesn't work, the pupillary reflex will still stay the same. The near accommodation reflex is different from the pupillary light reflex. It specifically refers to the fact that you get pupillary constriction, like in the pupillary light reflex, but you get it from converging onto a near object, which causes miosis, pupillary constriction, and convergence of both eyes onto it. The Edinger-Westphal nucleus is again involved, except that it now triggers meiosis and accommodation in addition to pupillary constriction, as well as convergence via the medial rectus muscle. Because this uses a different part of the Edinger-Westphal nucleus near the dorsal part, when you have a compressive lesion in the dorsal midbrain, it actually spares the accommodation near reflex while still affects the pupillar light reflex. So you get what's called light near association in Perinaud syndrome. You also interestingly get the same thing in neurosyphilis. Cranial nerve 4 is our trochlear nerve. It's the smallest and longest intracranial nerve that we'll be talking about. The interesting part about the trochlear nerve is it decussates to the other side along the anterior medullary velum. Because of its course outside the cone, after retrobulbar blocks, the superior oblique muscle is the one that's most likely to be spared. The trigeminal cranial nerve is the biggest and very complicated. It's both sensory and motor. The sensory part is it innervates most of the face, and the motor part, it does something with chewing. The pons is where we're interested in because that is the sensory part for the light touch of the skin and mucous membranes. The spinal nucleus is the one that processes the pain and temperature, and this has an onion skin pattern. Now, if you look closely, this is different from dermatomes. The dermatomes are V1, V2, and V3. This specifically refers to which part of the nucleus processes which part. Because of this, if you have a brainstem lesion, you can actually get onion skin facial numbness instead of the typical V1, V2, V3 distribution. The trigeminal nucleus is very big. The two main things is the trigeminal ganglion lives in the Meckel's cave. The other thing is that the motor nucleus is medial to the main sensory nucleus, or the MSN, and the motor part innervates the muscles of mastication, the tensor tympani, and the tensor veli palatini. So those are all ENT problems. The ophthalmic division of the trigeminal nerve is V1. That's the part that innervates the tip of the nose, the forehead, and the upper eyelid. This is the most important one, and this is the one that can also give us herpes, inflammation in the eye, in addition to the skin. This includes the frontal nerve, the supraorbital and supratrochlear branches of the frontal nerve, the lacrimal nerve, and the nasociliary nerve. The nasociliary nerve is the one that does the cornea of the iris and the tip of the nose. The V2, or the maxillary division of the trigeminal nerve, exits out of the foramen rotundum and innervates the lower part of the eyelid and the cheek. The nerve we're most interested in is the infraorbital nerve because that's the one that innervates the stuff near the eye. V3 is the mandibular division. It exits out of the foramen ovale and it innervates the jaw. Does not have any eye involvement whatsoever. The abducens nucleus lives right by the facial nerve nucleus at the floor of the fourth ventricle. Because of its association with the facial nerve, if both the facial nerve and the abducens nerve are affected, this likely indicates a pons lesion. The abducens nerve has the longest subarachnoid course out of any nerve, therefore it could be the one that's first affected by high intracranial pressure. The facial nerve does the muscles of the face. The ones we're mostly concerned with is the orbicularis oculi. The lower face receives contralateral innervation, but the upper face, the eyebrows, receive bilateral innervation, which means that when you have an ipsilateral stroke, half of your face will be paralyzed, but your brows will still both move up symmetrically. This way you can differentiate if the facial nerve lesion is in the brain or if the nerve itself is affected. The facial nerve exits right through the parotid gland. Therefore, when you have a parotid tumor, it can affect the facial nerve. Also, when you're doing a parotid dissection, most likely you will cause a facial nerve palsy, as there's just no way to do a radical prostatectomy without it. The other thing to remember is that the most common site for Bell's palsy is at the geniculate ganglion. That's from the labyrinthine segment of the facial nerve. So the facial nerve is the one that's responsible for tearing and salivating. The lacrimal nucleus will then go through the geniculate ganglion and then travel to innervate the parotid gland via the greater superficial petrosal nerve. Because the facial nerve innervates both the salivary and the lacrimal pathway, damage to the facial nerve, which causes aberrant regeneration, may lead to crocodile tear syndrome. In this case, when you're chewing, instead of making more saliva, you start crying. The cavernous sinus is actually pretty important. There's a bunch of stuff that is in the cavernous sinus, and when there is cavernous sinus thrombosis, it kind of knocks them all out. It's a bad deal. So let's again discuss what is in the cavernous sinus. In the cavernous sinus, we have cranial nerve 3, cranial nerve 4, V1, and V2. The abducens nerve is unique among the nerves that it runs free in the cavernous sinus within the blood flow, versus the other ones are kind of attached to the cavernous sinus wall. The ophthalmic veins drain in the cavernous sinus, which then drains in the rest of the cerebral circulation. The main clinical correlation here is that the superior sagittal sinus can sometimes get thrombosis. And when you get thrombosis of the dural sinuses, this increases intracranial pressure and is often associated with intracranial hypertension. Therefore, if you do notice that on an MRV, it is sometimes possible to stent that area and resolve the intracranial hypertension. The circle of Willis is very important, and the main thing to remember is the eye stuff is mostly anterior, but if you look, there's still blood supply to the pons, the entire brainstem, so all of it really is important. The posterior communicating artery is the one that connects the middle cerebral and the posterior cerebral arteries. That is the site for the posterior communicating artery aneurysm, which has a tendency to pinch cranial nerve 3. But the anterior communicating artery is actually the most common site of intracranial aneurysms of the circle of Willis, which can push on the optic nerve.